Next up, I'm excited to introduce our speaker today, Dr. Ben Miraglia, graduated from SUNY at Buffalo School of Dental Medicine. He's been practicing dentistry in Mount Cisco in New York for over 30 years, 20 of which have been dedicated to orthodontics, understanding and educating early jaw growth development educating on early jaw growth and development for kids. He is widely recognized for his lectures and continuing education courses, focusing on clear aligner therapy and craniofacial development and development related to sleep breathing disorders. Dr. Miraglia is also the VP of Clinical Education at Candid Pro. I have had Dr. Miraglia speak a few times now, and he is very passionate about ortho. He's knowledgeable and he's funny. So I'm happy to turn things over to Dr. Miraglia and we can get started.
Oh, yeah. Thank you very much, Nicole. And yep, today our topic is going to be the benefits of clear aligner therapy. So we have an amount of time, and then we'll handle some Q&A. If you have some questions, I'm happy to answer those. And we'll just dig right into this. So let's get to our pathway. Well, you already heard the intro and you know my credentials. Well, everything begins with patient screening. And so when we talk about screening, it's the hygiene chair, because our hygienist usually has the best relationship with the patient and they have the most amount of time with the patient. So as far as education goes, the hygienist can go a long way into introducing a lot of this, but there has to be some sort of screening. And what we're thinking about are what are the common symptoms that we all see. And so these are things that you'll recognize in your own practices. You don't need percentages from me. You can think about how often you see this in your own practice. So misaligned teeth, in other words, crowded teeth, loosely speaking, but how many adult patients come into your hygiene schedule on the hour every day and then have crowded front teeth, misaligned teeth? That is something we see very common. And you could either be keeping score by who's coming in with crowded teeth or which adults come in with perfectly straight teeth that have a nice bite looking like you're typing on. I think we would mostly recognize that's rare. How many adults come in with recession? And so again, the adults coming into the hygiene chair every hour on the hour, it's almost difficult to find a patient that doesn't have some recession. So we're going to find plenty of adults that have recession. Abfraction, we're going to find plenty of adults that have abfractions, those grooves on the gum line there. So sure enough, if our hygienist has the hour with the patient, time to communicate, obviously can recognize these things by what we call screening. And then, of course, a chance to kind of create that handoff to the doctor, because we're going to be calling the doctor in for an exam. We have a chance to do a nice handoff with this information. Chipping or wearing of the incisal edges or cusp tips, and what we would consider this to be beyond normal kind of chewing food wear and tear. So parafunctional habits, the patient has different habits of clenching, grinding, whether it's day, night, or both. And all of a sudden we recognize that we're chipping or wearing things more than we should if we were just chewing our food. And tooth sensitivity is fairly common, and patients are happy to divulge that this is sensitive or that's sensitive. And, and we give out sensitive toothpaste quite a bit, but there's an opportunity to think about these categories that we see here in the screening by our hygienist, so that as the exam is going to the doctor, that's going to be where the diagnosis takes place. So basically we're building a pathway where we have a chance to educate our patients. What are we seeing? And then how do we feel about opportunities to treat these? Now, we can treat things like this in the symptom column. We can also treat things like this in the cause column. And so we're much happier to treat the cause versus the symptom. It can be a lot different. And sure enough, the things that we see here, recession, abfraction, wearing of teeth, tooth sensitivity, the commonality here is that occlusal trauma usually drives most of this. So occlusal trauma delivers these changes. And if we know we've got occlusal trauma, there's a pretty good chance we have a malocclusion on our hands or a bad bite. And that bad bite is deteriorating the patient's mouth ahead of schedule, which will require more dentistry. But of course, dentistry that's necessary sometimes treats the symptom, not the cause. So it doesn't mean we don't need the dentistry. We still have to do it. But this delivers that kind of handoff to the doctor, because the hygienist is in the screening category, but the doctor has to be in the diagnostic category. So we've got to make a diagnosis. And there are symptoms and then there are causes. So we are thinking about, what is our symptom? What is our cause? So if we're thinking about crowded teeth are a symptom. The teeth are a symptom, but what we have as a cause of the crowded teeth has to do with the underlying arches that are below. So the foundation. So we talk about an improper arch form, and they're easy to see. Anybody can screen for this, or, the doctor certainly can diagnose a V-shaped or omega-shaped arch. An improper arch form delivers a malocclusion with occlusal trauma. So Our patients that we would recognize having a V-shaped arch, they have no chance to close their mouth, and we would then say, oh, they have good occlusion though. And same thing with an omega-shaped arch. We don't have the opportunity to say, oh, well, that's an omega-shaped arch, but when the patient bites down, they have a good occlusion. These type of arch forms deliver a poor or maloccluded connection of the teeth. So we're looking for this type of arch form. This is an ideal arch form. An arch form that is a broad, wide dome, which would kind of, if you're thinking about architecture, you're thinking about the Roman arch. The Roman arch is the broad, wide dome. Well, when we see a beautiful upper arch like this patient has an opportunity for the teeth to actually close together and land appropriately. So when we have that good bite, we have good occlusion, there would be little to no occlusal trauma in this type of mouth with this arch form. So we're looking to convert an improper arch form to a proper arch form. And we're recognizing that most of the adults coming through our chairs are going to show this signs or symptoms. And then we're going to think about, what are we diagnosing? Improper arch form is at the top of the list. Now, item number 2 that we can make a diagnosis in is the arch width. There is such a thing as improper arch width, and this is measurable. And it turns out that transverse measurement, a lot of research was done at the University of Michigan under a Dr. James McNamara. And it turns out the shortest distance between teeth 3 and 14 measured at the gum line is considered a transverse measurement. So we are looking for the distance between 3 and 14, and we're making this measurement because his research concluded that healthy, stable occlusions that develop naturally have a 35 to 39 millimeter transverse measurement. And so we know from his work in child growth and development, watching kids grow and develop, it was the group of kids who grew up and their teeth kind of went where they belonged. They had good occlusion. They didn't have orthodontics, didn't need orthodontics. And I know that's a smaller subset of children when you're looking at all the kids. Most need attention, but the ones that don't, it turns out they had one very significant measurement, and it was the most statistically significant predictor of their good growth and development was their width. So we like to measure the adults between 3 and 14. Now you can use a Bowley gauge. A Bowley gauge it's in your office somewhere, so you're going to have to find that Bowley gauge. Some of us don't use that regularly. It might be on the bottom of a drawer. The mystery is which drawer is it in. So I wish you luck on your endeavors trying to find that. Scavenger hunt today. So the Bowley gauge, wonderful tool, just a slide rule. You can touch the points to 3 and 14, or you could see all over the screen, I've got these cotton rolls here. Well, it turns out your cotton rolls are 37 millimeters long. So you can take a cotton roll, place it against one tooth, come across the arch and see what you've got. Because if you know your cotton roll is 37, you'll have an idea, well, what is my width? You can make a very good guess because dentistry is a game of millimeters. We probably would be able to guess, or you can take the cotton roll out and trim it with a scissor and go back in. Once the cotton roll fits perfectly between 3 and 14, you can measure it then to see what exactly is this patient's transverse measurement. And we'll recognize that as you start to see patients who have crowded front teeth, they're going to come in very narrow. They're going to measure less than 35 millimeters. So you're going to see narrow, crowded mouths. So here is a quick example of a before and after where we have improper arch form, improper arch width. The patient is sub 35 in their transverse measurement. But then post-treatment, which again, using the glidewell aligners, the pathway here is that we have expansion and proclination. We're going to move those teeth away. This is done without IPR, no interproximal reduction, and without any attachments. And once we get that patient to a point where they have proper arch form at an appropriate arch width, meaning they're right between that 35 to 37 range here, all of a sudden we have a wonderful opportunity for that patient to close their mouth and have good occlusion. On the left side of the screen, of course, that's going to be a malocclusion with traumatic forces, and that will deteriorate over time at a different rate than on the right side of the screen, where the teeth will actually come together appropriately and protect each other, which is what they were meant to do should they be receiving vertical load. Then, of course, the third item is improper buccolingual inclination. So these are long words, but they're a very simple concept. And so buccolingual is cheek-tongue inclination. How are my back teeth leaning? And it's easier to actually see the difference than to describe or write the difference. So on the left side of the screen, the patient's posterior teeth are more vertically inclined, whereas on the right side of the screen, the patient's posterior teeth are lingually inclined. So lingually inclined teeth have the connection delivering occlusal trauma through horizontal loading. So the patient whose lower and upper teeth are lingually inclined, this is what it looks like. This is the look of improper buccolingual inclination. Back teeth leaning towards the tongue excessively, whereas we would really like them to be vertical and upright. So all of this, what does it mean? Well, I pulled this picture from a 1970 book called A Textbook of Occlusion, one of the early days of descriptions about occlusal traumatism. And so improper arch form, improper arch width, and improper buccolingual inclination deliver destructive horizontal forces to your teeth, gum, and bone, otherwise known as occlusal trauma. So horizontal or lateral force is bad for the teeth, gum, and bone, malocclusion. Vertical loading is appropriate. And sometimes we say vertical or axial, depending upon what you're reading. Vertical or axially loaded teeth, that delivers occlusal health because the force is then distributed through the crown, through the root, into the surrounding bone evenly. And vertically loaded teeth have occlusal health for the teeth, gum, and bone, whereas the horizontal loading is very bad and gives us the destruction that we see. And when we see occlusal trauma, we recognize that, okay, here comes the recession, here comes the abfraction, here comes the chipping and wearing, and here comes the tooth sensitivity, because all of those things are related to occlusal trauma. So the screening process turns into a diagnostic process, and all the while, what we're looking at is how can we improve our patient's oral cavity? And the same way we might screen for cavities, we should be screening for occlusal trauma. And certainly now we start to diagnose the things that lead to occlusal trauma, which would be improper arch form, improper arch width, improper buccolingual inclination, delivering us a situation where the teeth, gum, and bone will deteriorate ahead of schedule. So what can we get from malocclusions? All kinds of trouble, right? Malocclusions, the more crowded the teeth, the more poor the hygiene. It's difficult to clean those teeth, so they will deteriorate faster. There will be more tooth wear. There will be teeth shifting, and it is a constant shifting, not just a small amount, then they stop. We're going to see tooth fractures, recession, abfractions, vertical bone loss, horizontal bone loss, restoration failures when we're putting them into mouths that have occlusal trauma, muscle soreness, TMD, joint breakdown. So the entire oral cavity, the entire complex can suffer the consequences of the occlusal trauma delivered by improper arch form, width, and inclination. So of course, we're going to be talking about, what is a GP doing all day? And this consideration is important because as a general dentist, we do fillings, we do inlays, we do onlays, we do crowns, bridges, veneers, all kinds of implant work. Basically, we're doing a ton of restorative dentistry on our patients all week long. So there's the restorative dental category, but then there's the endodontic category, root canals. So as a GP, your choices are simple, right? We either do root canal for our patients or we refer them to a specialist. Then there's the periodontal category where same thing, two choices. We either do the periodontal treatment or we refer them to a periodontist. Well, if you think about the restorative endo and perio exposure that you're seeing, all of the restorative endo-perio procedures that you're doing, I want you to consider this next week when you're in practice and you're treating one patient after the next in your chair. How many of the patients that we are seeing for restorative endo-perio have proper arch form, proper arch width, and proper inclination, meaning look like the patient on the left side of the screen? The bite on the left resembles a typodont style occlusion, which is very healthy and of course has occlusal health built into it by protecting itself through vertical loading. But the patient on the right who has the improper arch form, the improper arch width, and the improper inclination, I think when you start to look at your restorative endo-perio procedures, you'll be checking a box. Ooh, that patient has improper arch form, improper arch width, and improper inclination. So welcome to the deterioration process that is delivered through the occlusal trauma. And of course, you're going to recognize over time that I am performing most of my restorative technique, most of the endo procedures or referring, and most of the perio procedures are referring on patients that have the malocclusions, ready for this, in the deep bite crowded category. Crowded deep bite is the largest kind of segment of malocclusion, and the class 1 crowded deep bite is the largest segment of malocclusion there is. And I think as you start to record and see, well, what am I working on? Where am I restoring and then doing endo and perio? You'll probably notice that, most of my procedures are done in the class 1 crowded deep bite malocclusion. And they will check the boxes of improper arch form, width, and inclination. Now, of course, the consideration is that we have to fix these things. We have to restore the teeth. We have to do endo. We have to do perio. These are necessities. However, we have to think about this just a little differently. Restorative dentistry, endodontics, periodontics, a lot of these procedures, when there's occlusal trauma from the arch form, width, and inclination, we might be treating in a symptom category as opposed to cause. And here's how we'll think about this. There is no restorative procedure that changes the arch form, width, or inclination. And certainly there is no endo or perio procedure that will change the arch form, width, or inclination. So if our procedures in restorative endo and perio have not changed the arch form, width, or inclination, the patient walks out of our chair with the same malocclusion that they sat down in, again, horizontally loaded, and now the clock just resets. Let's break that down. Let's break that down, because their mouth will deteriorate ahead of schedule, and we will be doing repetitive dentistry at some point. So we think about arch form, width, and inclination, and there's really only one pathway to solve that, and that's tooth movement. So tooth movement is the pathway to solve arch form, width, and inclination, and the patient basically then enters the category of comprehensive care. And comprehensive care means we are going to do restorative endoperio procedures that are necessary, but we're also going to do the tooth movement, and that becomes the single most important benefit of clear aligner therapy, in that clear aligners are capable of solving the arch form, width, and inclination, so that we can change a patient from occlusal trauma, from that horizontally loaded posterior segment, to a beautiful vertically loaded posterior segment. And so our pathway towards better oral health, of course, there's restorative endo and perio procedures can make for better oral health. However, the real way to take care of the occlusal trauma is tooth movement, and that's where our clear aligners come in. So who are these patients that we're seeing every day? Well, they're walking into the hygiene chair pretty much every hour on the hour. We have the largest segment of malocclusion is the crowded deep bite, and in the class 1 category, we can say. So for those beginning, thinking about, well, I don't know where to start, you don't have to start on class 2 and 3 patients. You know, that is additional training and experience. We don't have to begin with those. The good news is the patients that are class 1, that's a majority, and the patients that are crowded deep bite, that's the majority. And they'll look like this. These patients look like this in our hygiene chair, and they have mild conditions, but all of these patients can benefit from clear aligners because it is a clear aligner tooth movement technique that can solve their arch form, width, and inclination and deliver a healthy occlusion. So when we're thinking about beginning and how we would start this process, it's best not to get in over your head. You don't want to be overwhelmed in the most difficult class 3 bite of your life, because that's not the best place to start. So this little grade begins on the left where it's less difficult, and on the right it ends where it's more difficult. So we are kind of shading across this group. And the crowded deep bite and spacing cases are in the left kind of corner of this. So crowding is less difficult. Deep bites, less difficult. Spacing, really easy, but mostly we're going to see crowded deep bites. As we work our way across, we start picking up open bites, and there are some open bites that are in the easy category, but more often than not, it's a little more challenging. Cross bites get a little more challenging, and the underbite or the class 3 bite is the most challenging. The reason this is set up from less to more difficult isn't that aligners can't do it. It's just that on the left side of the screen, when you're talking about class 1 crowded deep bites or some spacing cases, they are aligner-only techniques that solve those patients. So we do want to begin our clear aligner therapy and how we want to benefit our patients in a category where we're also comfortable. So you begin with the crowded deep bites because you're doing these treatments with aligners alone. As we work to the right of the screen, basically you're starting to incorporate auxiliaries. So the difference one side to the other, as the malocclusions get more complicated, we're using clear aligners plus auxiliaries. So there is such a thing as Glidewell aligners plus, which means now we need elastics, or now we need mini implants, or now we need expanders, or now we need, and there's X, Y, and Z involved with additional treatments. So clear aligners with adjuncts can handle more complex malocclusions, but that's not where we should begin our process. We want to just understand that in the class 1 category, we have so many crowded deep bites that we could be working on that could be aligner alone therapy that are rather routine and simple to fix. And then, of course, we've got a pathway to do it with a beautiful, beautiful product. Welcome to Glidewell Clear Aligners, powered by Pro Monitoring. So there are a couple of differences that are very important. So obviously there's an opportunity for you here, and you may be using a competitor currently, or you may not be in the clear aligner game right now, but let's talk about the differences. And one of the most important differences is the model formation. So the model being formed in order to produce what we would like to use as a minimal IPR and a minimal attachment technique, we have to produce our model differently. And so the technique of the model making is that we do not block out the gingival embrasures. The gingival embrasures are not blocked out, so it is a direct representation of how the patient is in their mouth clinically, whereas most of the competitors block out the gingival embrasures. By not blocking out the gingival embrasure, the aligner can then be formed into both the buccal and lingual embrasures. Now, the aligner forming into the embrasures engages all of the undercuts around all of the teeth. This is the pathway by which we reduce or eliminate attachments. By having the aligner engage into each of the gingival embrasures, basically it transfers the attachment on the buccal, which you see on the right side of the screen, which is necessary for when you block a model's gingival embrasure and you scallop trim the aligner, you need attachments. You need an undercut to grab. But if we grab the undercuts in both the mesial and distal buccal and lingual around each tooth, the tooth is now your attachment. So now the entirety of the tooth is surrounded and engaged in an undercut all the way around it. So you have a grip on that tooth that creates the tooth being the entire attachment. This is the pathway to do no attachments or minimal attachments. So we're going to have a model that is produced without blocking the undercut. Then the trim line. Our trim line is different. We do use a straight extended trim line, and that's because there's a difference between scalloped and straight extended trim line. So it turns out UNLV did a research study on the different trim lines available to clear aligners, and it was the straight trim line that decreases the flexibility of the aligner. And by keeping the aligner or having it retain its initial form longer, it has better fit on the teeth and better expression of the tooth movements. Whereas the aligners that were scalloped, they deform quicker, and instead of maintaining their shape over the entire time it will be used, as they deform, it no longer has a good grip on the tooth and cannot express the movement as well. So it turns out that a straight extended trim line is better, and the research is pretty significant. So when we take a look at the numbers, it does kind of show a significant difference between a scalloped trim line and a straight extended trim line. Now, the scalloped trim line, we look at the blue picture on top. This happens to be referring to the pull-off force. In other words, what is the retention on the aligner on the teeth? How much of a grip does it have? Well, when you use a scalloped trim line with 6 attachments across the front teeth, the pull-off force needs to be near 9 pounds, 8.86 pounds per square inch. So it takes 8.8 pounds to dislodge that aligner. Again, scalloped with 6 attachments. When a straight extended trim line is made over a model that has no gingival embrasure blockout, the perpendicular pull-off force, or the force to dislodge that aligner, is double that. It's 16.276 psi. So no attachments with a straight extended trim line is double the force or double the retention. Now, because we're not blocking the gingival undercuts and we have a full engagement of the aligner to the entire tooth surface, it turns out that this delivers the better contact to the tooth over the time it's being worn. The scalloped trim line, you can see by the color coding, where does the scalloped trim line aligner engage the tooth? Primarily, it's the incisal half. The incisal half with very little bit of extra attention at the edge. Whereas, take a look at the picture below. The straight extended trim line engages a tooth from mesial to distal, from incisal to gingival. And all of a sudden, you have the entirety of the tooth is engaged in that surface, which will lead to, of course, better tracking and better finishing. So it turns out the straight extended trim line was the best performing aligner shape and cut that delivers better tracking through its better fit and retention. So the force on the teeth is the display of that. So of course we use a straight extended trim line. Now we are a full service aligner service here. So what you have is the availability of attachments. In more complicated cases, yes, more complex malocclusions, attachments are common. But when you're thinking about class 1 crowded deep bite, very rare to need attachments in those cases based on the cut and trim of the model and the trim of the model and the aligner cut. So we don't use them very much in the kind of mild to moderate cases. It's more in the extensive ones. We do have IPR available. So while we use minimal to no IPR, it can be used. It's by provider request. If you have a black triangle or it's like that poppy seed look and you want to reduce it, IPR 0.1 or 2 could have a place there. We're not likely to give you a plan that has 0.3, 0.4, 0.5 like shown on the screen. That's a little too heavy. We don't just want to cut and spin the front teeth. We'd like to solve the arch form, the arch width, and the inclination. So we will give you by default an expansive technique to bring the teeth where they belong. Pontics are available. We're GPs. We might have to replace a bridge or a missing tooth. We would like to have a Pontic in the aligner. So for the aesthetics of the treatment time frame, it's delivered. We can use bite ramps. If you're further down the road in your education, then all of a sudden you recognize maybe there's a place for bite ramps in more complicated cases. So we have those available as well. Part of the dynamics is that we have this easy to follow and clean packaging system that comes with everything the patient needs in one neat, clean, and really well presented box. And that includes what we're going to review again as this scan box in the upper center. And the scan box is where we introduce the tracking, because we're going to be offering monitoring to your patient. And of course, this is a way to make sure that patient stays on track. The state-of-the-art remote monitoring, there's an app built into, obviously the patient will download. So the treatment involves an app. The patient will connect their phone to that little scan box. The tube is where they use to have lip seal, and basically around the tube, it becomes the lip retractor. And that patient basically will take a scan every 2 weeks to tell them that the tracking is perfect. So the AI built into this knows if every single tooth movement that should have been expressed in those 2 weeks was. If every single movement has been expressed in the 2 weeks, the patient gets a go-ahead, move on to your next aligner. But if every movement wasn't expressed, that's when the patient is told, wear it one more week. And when you wear it one more week, it will deliver the movement. So most patients get the go-ahead because they're, wearing their aligners well. But the improved compliance comes from knowing that there is continuous engagement, and I will have to kind of prove accountability that I have worn my aligner well. The only reason that there may be a denial to move forward and have to wear your aligner one more week would be, I didn't wear it so well for 2 weeks. That would be the number one cause. So if I didn't wear my aligner so well, it might tell me to wear another week, which is a benefit to have that safety net, because now you have the opportunity to regain that movement, as opposed to just moving on and missing out on the opportunity, which then will propagate itself and compound towards the end. So the remote monitoring is fascinating. I'm going to have this little video play for a moment so you can see where we are here with the monitoring.
We understand your goal, to achieve a beautiful smile within the expected time frame, or even earlier. Here's how we can help. Traditionally, clear aligner treatments rely solely on in-person visits. If your treatment progresses faster than expected, we won't know until your next visit. If there's an issue during your treatment, we'll catch it at the next appointment, and that sets back your progress. So your overall treatment timeline may be extended. Are you busy or traveling? Rescheduling visits also adds extra time to your treatment. With only in-person visits, it can take longer to achieve that beautiful smile. This is why we offer you Pro Monitoring, a smart technology to help us monitor your treatment progress remotely. Take your scans from anywhere, and we'll keep everything on track. This way, your doctor knows exactly what's happening with your treatment and how you are progressing, and we can schedule your office visits at the right time. If your treatment progresses faster than expected, we will know right away and you will be ready to move ahead. If there's an issue during your treatment, it will be detected promptly without wasting precious time. Busy or traveling? No problem. You can use Pro Monitoring anywhere and at any time. It's easy. The Pro Monitoring app will notify you when it's time to scan. Just follow the instructions. Pro Monitoring has helped thousands of people complete their treatments with fewer delays. But remember, it only works if you regularly take the scans as requested. Experience a quicker path to your perfect smile with Pro Monitoring.
So that is how we keep our patients on track. Now, on day one, they take a scan. The first aligner goes in, they'll take a scan. That is their baseline, and the AI knows that is not a match. So we are not a match because the aligner is different than the patient is at day one. It's got to get the movement done for those 2 weeks. The patient will take a scan at day 14 and then follow the instructions. And of course, everything is in an app. So they have easy to follow instructions there. Once the patient gets their scan uploaded, they'll be told you did a wonderful job, move on to your next aligner, or wear that one more week and scan it again to confirm that you have all of the movement necessary recorded. And then, of course, we have opportunity to see the difference that Pro Monitoring can do for a patient. So this happens to be a study that involved 200 patients. 100 were treated in the control group as a conventional aligner patient. And then the other 100 were treated with a remote monitoring involved. And sure enough, the office appointments are significantly different. So these 100 patients in the experimental group, the attempt was made to treat them with 2 visits only, a start and a finish. And so it came up to 2.1. That has to do with what we're going to get to in the additional aligner stage here. So what will that mean for your team? Well, your team members, there are hours involved with those 7 visits, and the time involved with 2 visits becomes less than half of that. The refinements, it turns out 91 out of 100 of these patients had the need for a refinement, whereas in the remote monitored group, only 14% of the 100 needed a refinement, which would add 1 more visit. And so adding a visit at 14% becomes a 2.1 average for these patients. The duration of treatment, of course, if 91% are getting more aligners, you're going to have a 17-month average here, whereas it's a 10-month average in the group of 100 that are monitored. Basically, when you're not monitored and your eye can't pick up little differences along the way, a patient might wear all 20 of their aligners, but it won't be finished or perfect, and you need more. Whereas along the way, when the AI in the monitoring knows every tooth movement was expressed, your patient is only moving ahead as the movement before was accomplished and is perfected. So you stay on track more often, and these numbers are significant differences in that you have an opportunity here to reclaim chair time. And all of this really adds up to profitability. So when we think about this monitoring that's going on, your patient is taking the scan in their phone, but it goes right to your portal. So just like you have a site where you go and look at your patients and you've uploaded their photos and scans, then you've seen their treatment plan and approved it. Then as they take their scans along the way, they're recorded in the portal, and you can see the little green circles going across the screen. That's a successful scan. Every 2 weeks was beautiful. So when they move along, it starts to stitch it together. So one after the next, the videos are put together and they're kind of lined up and sent to the patient. So the patient actually has each 2 weeks a stitch added to their thing, and they can kind of show the progression of their teeth moving right along. So everything you have in the portal shows you, and you're welcome to see it every 2 weeks, meaning follow your patients, but it's not necessary. Should your patient receive a no-go, then all of a sudden you get a little note that says they're going to wear it 1 more week. So you kind of have a reminder, oh, and they wore it 1 more week, now they were successful. So you get a little notation that tells you if they're having any trouble along the way, which means you get to kind of forget about your patient in between while they're being monitored all the way along, knowing that they're going to walk in at the end of treatment being perfectly aligned in a good spot and be finished. So we should share a few cases with you to give you an idea of what's possible. These cases share similar credentials in that we have a number of aligners. This particular one is 16 aligners. There was no interproximal reduction performed. No attachments were used, and this is a 2-visit case. And you could see in the before segment above, the patient has that mild malocclusion. So again, there's an amount of crowding of the lower teeth, and we would recognize that it would be a healthy result to have these teeth straight, well aligned, and then of course in a good occlusion, because once you have an amount of crowding like this, you have a malocclusion on your hands, and there will be trauma to these teeth, and it will change the gum, the bone, the teeth. Everything here is going to deteriorate differently as this gets worse over time. So we know where this is headed if we think about how this patient might progress with no treatment over 5 years, 10 years, 15 years. This will be worse over time. Whereas after the 16 aligners and 2 visits with no additional and no IPR, no attachments, we have full alignment of the teeth. While the teeth are nicely aligned, and I know we tend to focus on that, something else to notice is the full gum line remodeling. So all of the gingival tissues have remodeled to normal. And this patient has not had any type of graft or scalpel or electrosurge or no gum tissue work, no treatment to the periodontal aspect of the case. It's just tooth movement with the aligners. So with the aligners, all of a sudden you have alignment, better occlusion, healthier gum tissue. So the gum tissue will remodel according to beautiful tooth movement with a beautiful bite. And we should expect this to happen throughout our treatment as we address, the expansion and proclination of these teeth where they belong. And it is possible to get all of the teeth to fit without IPR. You just have to move them all. So all of these teeth get moved slightly. And instead of the lower arch being very narrow, and you can see the difference on the top picture, how narrow the lower arch is and yet how wide it is down here. Widening the arch means we fit the teeth in. And when you widen both the upper and the lower, you end up having more vertically loaded posterior teeth. So now we have the upright position of all the teeth, a beautiful bite, and healthy gingival architecture to show for it, all done with 2 visits. Same thing here. Again, 16 aligners, no IPR was used, no polishing of the teeth, no attachments, and again, in just 2 visits. So this arch is a little more collapsed. And so you can see by the curves of the occlusal groove and how narrow things are, all of a sudden we have this omega shape. You can call it V or omega shape, anterior crowding, crowded deep bite, narrow arches. And when we look at the back teeth, they are leaning in. So we're thinking about, oh, improper arch form, improper arch width, improper inclination. All of this collapse of the posterior delivers the crowded anterior teeth. And lo and behold, when we take that patient through 16 aligners, solving for the arch form, the arch width, and the inclination, now the arch is wider. We can see several millimeters of arch width. We have a beautiful correction of the deep bite. The gum tissue is remodeling nicely, and the arch form is now corrected as well with the uprighting of the posterior teeth. We can see the difference. The posterior teeth lingually inclined, leaning in. This mouth on the left, pre-treatment, has occlusal trauma through horizontal loading. On the right side of the screen, we have full vertical loading thanks to the uprighting of the posterior teeth. It is the uprighting of the posterior teeth that increases the VDO and corrects the deep bite. We're not looking to change the deep bite by anterior intrusion. That's less predictable, and that's not really the right diagnosis, that the teeth were over erupted. So we don't want to try intrusion there. We want uprighting the posterior teeth so they can connect appropriately and deliver a resolution of the deep bite. This is a very nice change done in 2 visits thanks to the monitoring, and again with 16 aligners and no attachments. When we get to the third case here, we're going to see similar. It's a little more collapsed, and then there's a little more expansion to get rid of all this crowding. So this case is a touch worse, and of course we have more aligners. So here we are at 25 aligners. 25 aligners, similar in that there is no IPR, there are no attachments, but it took 3 visits. The patient did need an additional set refinement. So there was 25 is the total. 25 is the total. There's an initial set, then a remainder. So we get 3 visits to treat this case. And sure enough, we can again look at the beginning, improper arch form, inappropriate arch width, that's too narrow. And then of course, the improper buccolingual inclination. The back teeth are so collapsed and leaning in that this patient could only deliver occlusal trauma to all of their teeth like this. And we recognize how much crowding we have here is very significant. But the transition here is in treating what we diagnosed. We diagnosed improper arch form. We would like to change that omega shape arch to a beautiful Roman arch, let's say. We recognized improper arch width. This is a narrow arch. It is sub 35 millimeters. We need to get in that range above 35 millimeters. So we need to expand. We can recognize the posterior teeth are leaning in. And when the posterior teeth are leaning lingual, they are subject to occlusal trauma from horizontal loading. We want to upright those teeth, which we can conquer that too. So 25 aligners is 12 months. In 12 months' time, we developed this arch without any IPR. And look at the, again, I know we like to focus right away on the teeth. They're straight. It's a beautiful bite. An absolutely perfect vertically loaded occlusion. But how about the remodeling of the gum tissue? Look at how ideal the gum line can remodel just by guiding the teeth where they belong. So there is not restorative dentistry here. This is just doing the aligners with a little bit of the whitening gel. So using the Glidewell clear aligners can deliver a correction of the arch form, the arch width, and the inclination. And sure enough, you can have a beautiful occlusion. The big difference here is that on the left side of the screen, that is an unhealthy oral cavity. Whereas on the right side of the screen, that is a healthy oral cavity now. So we have the opportunity to solve for aesthetics. Of course, the patient on the right after treatment has a beautiful smile that is going to be gorgeous, but aesthetics is only one category. How about health plus aesthetics? If we're looking for the healthiest oral cavity, we want to solve for improper arch form, improper arch width, and improper inclination, not just cut and spin the front teeth. This is a no IPR type of case. We are moving all of the teeth to deliver beautiful occlusion. And to contrast it, if we just were to do a bunch of IPR and cut and spin these teeth into place, IPR and aligning the front teeth only just delivers straight front teeth. It does not correct the arch form, width, or inclination, so you still have occlusal trauma with that technique. Whereas this technique, to go ahead and move all the teeth where they belong, delivers a full resolution of the malocclusion. You have taken this patient from an unhealthy oral cavity to a healthy oral cavity through improved occlusion. And again, it is a very simple class 1 crowded deep bite. It took a whole 12 months to do that in 3 visits. Anyone could do this, and this patient walks into almost every dental practice every day coming through hygiene. All right, let's take a look at another one real quick. Patient here, 26 years old. Did you have braces as a teenager? I did not. Okay, well, if you didn't, wonderful. You avoided that whole trauma, which was only going to fall back to this if you stopped wearing your retainer anyway. So what a bonus. The patient didn't wear braces. but we could recognize right away, well, we have that, look at this, crowded deep bite, class 1 malocclusion. And if we want to think about this 26-year-old, right? How do you think these photos would look if we didn't do any treatment? We're not going to use clear aligners. We're just going to photograph this patient every 5 years. How do the teeth, gum, and bite look 30 years old, 35, 40, 45, 50, 55? Just do the time lapse in your head of this patient going from 26 to 95. What does this oral cavity do under these conditions? And it will deteriorate ahead of schedule. So while this 26-year-old doesn't have a ton of dental, endo, or perio procedures, it's coming. This type of occlusion doesn't get to avoid dentistry. It will deteriorate ahead of schedule, but we have an opportunity to fix it early. So again, the number one benefit of clear aligners is not straight front teeth. It's a beautiful, healthy oral cavity. And that's if we take the approach of treating the arch form with an inclination to deliver a healthy occlusion. The patient has a wonderful set of roots and good bone around her teeth, great candidate for orthodontics. This model kind of shows the back teeth widening because, of course, we're narrow. So we'd like to know that the models show the back teeth widening. When we go to the side view here, we can see the occlusal views show a little better, the back teeth widening. And as the back teeth widen and the front teeth are aligned, everybody fits in without attachment and without IPR. The tracking shows up across the screen on top, where at aligner 1, they take their scan on day 1. It's not a match, so it shows up as a red square. We are not a match. 2 weeks later, it is. The scan proves, yep, you wore it well, move along. But aligner 7 was worn for an extra week. They got a no-go after 2 weeks. That's an extra week. It goes ahead. Aligner 9, you have to wear it an extra week as well, and so with 10. So going through 16 aligners, the patient is able to complete their treatment in 16 aligners, having worn an extra week for 7, 9, and 10. If we didn't wear those the extra week and just went all the way to 16, they would fit. We would look at that and say, we probably have to make a few more to finish the job. But just sending out for more aligners to get them back can take 3 weeks, whereas we just wore the appropriate aligner the extra week to deliver the tracking. And now the patient finishes on time. So it gives us the opportunity again to correct the arch form with an inclination. And the patient that had collapsed posterior segments with horizontally loaded teeth now have beautiful upright vertical loading of the posterior teeth. And when you're uprighting the posterior teeth, the front teeth get to align without using any IPR. So the opportunity is tremendous to be able to treat the underlying malocclusion through its causes of arch form with an inclination, as opposed to just cutting and spinning the front teeth. We also get the correction of the deep bite as you're watching the uprighting of the posterior teeth deliver better contact posteriorly. The deep bite kind of fades away. So that brings us to a point where we could cover some questions, of course. Nicole, you want to open up and kind of read a few of those? We can go through as many as possible in the time frame we have. I'm happy I'm available. Mm-hmm.
Absolutely. We have a lot of great questions. So thank you so much for all this really good information.
No problem.
So the first one is, do patients need cephalometric analysis?
Not for clear aligner therapy. They do not need cephalometric analysis. So we're not changing the patient from class 2 to 1 or 3 to 1. And so since we're not going to be making a change of classification, clear aligner therapy is for tooth alignment, and you can do it without a cephalometric analysis.
Thank you. And then so for offices that aren't using intraoral scanners, can a protocol like this be done with conventional PVC impressions, or do you require digital?
I believe you can send in a PVS impression. We could probably reach out to someone who knows the answer, but I believe it's a yes. Yeah, we can still do that. And of course, through Glidewell, you should talk about opportunities to kind of make that leap into the scanning, which is kind of where dentistry is heading. So at some point, I think all of us will get there. But when you're ready, there are scanning opportunities available. The good news is we are agnostic. We can receive a scan from any scanner. So you don't have to buy the most expensive one. They're all incredibly accurate.
Thank you. So how do we diagnose skeletal versus purely dental malocclusion?
So in the clear aligner world, so in the clear aligner world, you are only doing dentoalveolar movement. So if you have crowded teeth, you have underdeveloped jaws. So your jaws are smaller. But when we talk about skeletal, you're referring to AP relationships. That would mean, are we class 1, 2, or 3? But again, the focus isn't on the class 1, 2, or 3 and changing 2 to 1 or 3 to 1. The focus with clear aligners is in the width, because the transverse component is not available from a cephalometric study. And a transverse component is directly measured in the mouth across the arch or off of a model or on a scan. But you're looking to attack the arch form, arch width, and inclination. because those are the components that deliver the horizontal loading and the deterioration, not whether your patient is class 1, 2, or 3. So class 1 doesn't mean healthy, and class 2 or 3 doesn't mean disease. You can have class 1 healthy occlusion or class 1 unhealthy occlusion. You can have class 1 malocclusion, in other words. Now, class 2 can exist as a malocclusion or it can exist as a healthy bite. It all depends on the width. So whether you have horizontal loading and deterioration comes from the transverse measurement, not your AP, and again, classification. The angle classification is not a disease classification. It's just how your teeth connect in a profile view. So it is not the recording of, oh, I have a class 2 malocclusion. No, you have a class 2, whether it's healthy or unhealthy, is based on the transverse component. So you have a full opportunity to treat the dentoalveolar complex with clear aligners, and they're more capable than brackets and wires at the transverse development.
Thank you. How effective are these aligners for either intrusive or extrusive cases for pre-restorative cases?
Yeah, so for pre-restorative cases, these are probably your best pathway forward to develop, again, proper arch form with an inclination. We saw a moment ago in the teeth that are crowded, they usually have different heights. And when teeth have different heights, when you're unraveling the whole entire arch, they will all level. So you can have whatever type of intrusion you need when the teeth are, in, let's say, a different height level. But extrusion, we have to talk a little differently about that. Number one would be, have we made a proper diagnosis? A lot of trouble comes from trying to extrude teeth that do not need extrusion. And so a lot of doctors in the clear aligner game who say, I am struggling with extrusions, there's a really good chance that tooth does not need extrusion. We have misdiagnosed the case. Think about the upper laterals are a perfect example. Most of the troubleshooting I get is, Dr. Ben, I can't get those laterals to extrude. Meanwhile, the patient has a deep bite. If your patient has a deep bite, the last thing you need is to be extruding the teeth, and they will resist that movement. So the teeth are telling you, I don't belong there. They will resist it. So we don't look to extrude teeth that don't need it, and certainly haven't been diagnosed as a tooth that needs extrusion will help you to avoid this problem. I have zero issues with intruding and extruding, primarily because of the diagnostics, meaning we go after arch form, width, and inclination and allow the aligner to level the arch, as opposed to treating the teeth in a vertical component. Oh, I have to move this one up and this one down. Never mind moving up and down. A focus on the transverse to deliver arch form, width, and inclination so you can have good occlusion. The aligner will take care of the leveling during that process. Shift your focus a little bit, and you'll notice after a while, oh, I no longer have to worry about extrusions not happening.
Yeah, that makes sense. Do you feel like there's any compromise to the gingival health with the elimination of the scalloping?
Oh, no, not at all. So I have used both systems for quite some time, and it turns out the accuracy of the scanning or PVS impressions is such that when the straight trim line is placed, it lands right at the gingival tissue. It's not an irritant to the cheek, the tongue, the lip. I have not, in now almost 4 years, adjusted a single edge on any one of these style aligners. Whereas prior with the scalloping, because the model is blocked out, that aligner will be away from the teeth and or gingival tissue. You have to polish those edges. So if you're using a scalloped cut on the aligner, you have probably had to either polish edges or your patients take a nail file to it and do it on their own, because it will rub the lip, cheek, or tongue, and you're going to have that experience with a scalloped cut. But the moment you switch to a straight extended trim line, you will have zero gingival irritation and or need for polishing the edge. That is an unbelievable dynamic. And yep, I'm living that dream. It has been 4 straight years not polishing an edge. In an unrelated note, I have a lot of brown polishing wheels for sale.
Yeah, you're saving more chair time that way also. Is there 2 weeks always the minimum wear time for aligners, for each aligner?
2 weeks should be, yeah. And that's a very long conversation we shouldn't tackle today, but the short story is that 1 week wear time is a little too rapid. You're increasing the force to get that to happen, and you're changing from remodeling to destruction. So you got to be careful. You can have an increase in risk to tooth, gum, bone, and nerve by doing a 1 week change. I'm not a fan of that. The healthy pattern to move the teeth is a 2 week interval, and that's where you have zero risk. So zero risk to the tooth, gum, bone, and nerve is happiness to me. I'm not trying to create a different problem, and I don't like taking risks. So I'm not a fan of 1 week wear time, because I think as you do that more, you're going to notice, uh-oh, I'm getting more recession. Oh, my teeth are more sensitive. Oh, I'm seeing some bone loss. I would be hesitant to do that because, again, increasing the risk by changing too rapidly is increasing the force. I'm not looking for more risk.
Yeah, makes sense. Okay. I have two questions on open posterior bites. So
Yes.
one is do you have issues with posterior open bites, and what is the solution for them?
I know, and I apologize for saying what I'm about to say. Try not to take it the wrong way, but there's a reason for it. Here we go. I have never had a posterior open bite in 22 years of using clear aligners. So in using aligners, this is thousands of cases going on. And so sure enough, I've been teaching this technique for, it might be 18 years now. But the posterior open bite is what you see. What you have is anterior premature contact. And you have anterior premature contact preventing the posterior teeth from coming together because you are using a retractive technique. So the technique is what causes it. It is not the aligner thickness. It is not the reasons that you were probably told. It is one reason and one reason only. The technique that went into your case was retractive. And so when you look at those treatment plans again, you'll notice that your top front teeth are coming backwards a little bit. And it really might be a lingual root torque that you have programmed in, and the lower front teeth are trying to intrude, but the intrusion is not predictable, so you don't get that, but you will get the pushback. And the moment you get that lingual root torque or pushback on the upper front teeth with no intrusion, these are going to hit sooner. So when you look at your treatment plans, you're going to notice that you're starting with crowded deep bites. You're going to have excessive attachments everywhere, sometimes doubles. You'll probably have in there lingual root torque, which in some instances, you'll see motion at the gingival area where the roots are being torqued in lingually. And when you combine all this with some IPR, basically you're doing a retractive technique on someone who has crowding. So your crowded teeth need to move the other way, away from the tongue, whereas the front teeth are coming towards. You'll also notice there's very little posterior movement in those treatment plans. The posterior teeth are not being changed, and they're being held in position, again, to unravel the front by IPR, intrusion, and retraction. And that is your pathway to the posterior open bite. Since I do not use that technique, I have never had one, nor will I, because I do not use that technique. Posterior open bite is the result of retractive orthodontic technique. And I understand a lot about it because I did troubleshooting for that particular item for over a 5-year period. And I have seen tens of thousands of these cases, and they all have the same exact treatment plan. Then, of course, when you're thinking about having the posterior open bite, you've got it in the first set of aligners. I would be willing to bet your second treatment plan had exactly the same credentials, because when you used your second set of aligners to correct the posterior open bite, and it was designed to do that, your posterior open bite stayed the same or got worse. And then, of course, you'll get a third set of aligners. But if it has the same exact technique, you shouldn't expect an improvement. Now I have to give the unfortunate answer of how do you correct a posterior open bite? And there is really only one best opportunity to correct a posterior open bite, and that would be discontinue aligner use and allow the patient to relapse. So the best, and it is the fastest, it's not the most pleasant, but you're going to have a conversation with the patient. If you would like to correct a posterior open bite, you take away the aligners, you stop using them, you have the patient come every month so you can take a look and a photograph, and one of those months they will be back together. They're going to relapse back together. When they have relapsed back together, you can start your case over. You can take a new set of records, you can remove all those attachments, and then you can develop a different treatment plan, because if you have the same treatment plan, you will get exactly the same result. But the best way out of a posterior open bite is to discontinue treatment and allow that patient to relapse. Otherwise, I can pretty much guarantee you will go year after year after year, round of aligners after round of aligners after round of aligners, and it will stay the same or only get worse because the treatment plan built was designed to retract your front teeth and intrude the lowers, which is unsuccessful. So I am sorry to be the bearer of the bad news, but once you know, you never have to have one again. You need no IPR, an expansive technique that moves your molars and premolars upright, and then you have your back teeth connecting sooner, as opposed to allowing the front teeth opportunity to hyperconnect or be in, occlusal trauma and early treatment or early contact. So yeah, it takes a while to teach that whole process. I tried to get it into a 5-minute span.
Yeah,
but
you did great. That was a really
there
good
it is.
explanation.
It's an ugly situation, the posterior open bite. I'm
Yeah.
sorry for having trouble with that. And if you need more help, reach out. I'll try to help you with it.
Absolutely. Okay, one question on the retainers. Do you use clear aligners for retainers after the completion of the treatment, and how long do these patients wear these retainers?
Oh, yes. After the glidewell aligners are used, there is a set of retainers. They're called permaform retainers. And certainly you can use a clear aligner as a retainer. I would say best practices would be to have multiple sets made, so you have a spare in case the patient would lose one. So we're in the practice of making 4 sets. They're delivered to the patient at the end of treatment. They should wear the first one for 3 months full time before going to overnight only. But each set will last 1 year. So even the first set, 3 months full time, then overnight only. 1 year out of each set is a very good pattern, and then you repeat it because the teeth like to relapse, and we'd rather hold them right where we put them since they look so beautiful now.
Absolutely. Well, we have a ton of questions coming in. I don't want to keep your time too much. Dr. Miraglia, this was fantastic. If you guys want, Dr. Miraglia is going to be speaking at our aligner symposium, November 15th and 16th. If you use the code early, you'd get $100 off, 2 nights at a hotel, and a free aligner case so you guys can try out this Candid Micro monitoring. So the cost for the symposium is $895, but I do have a couple of questions coming in about the cost for Candid Pro aligners, and it's $12.99. So I will leave this information into the chat box, and thank you so much for being here. We really appreciate it. We will not be having a webinar next week, so please join us in 2 weeks when we will have, as always, our business advisor panel, and our guest speaker will be Len Connor. He's a CDT, and his topic will be avoiding and treating over-denture complications. Thank you so much, Dr. Miraglia. This was great information. We really appreciate you being here.
Oh, thank you, Nicole. It's my pleasure.